Today we'll be performing a left hip arthroscopy with acetabular plasty and labral repair. This is a 39-year-old female who's referred to me from an outside facility. She's been having hip pain for approximately a year. She failed non-operative measures to include injections and physical therapy. When I saw her, I felt she had primarily what is called pincer impingement, meaning that if you look at the ball in the socket is covering the ball too much. So as she flexes up, she's squeezing the labrum, which runs along the socket. So she's impinging. And we can see on her CAT scan here that right in here she has what almost looks like a calcified labrum, but a bone spur that's overhanging there, and the labrum attaches along that rim, and that's causing the impingement process for her. When we saw her in the office, she was having mostly trochanteric pain, so pain on the outside of her hip, but I felt that was a reactive tendonitis secondary to her impingement process. We did an ultrasound-guided lidocaine injection test into the hip joint, and we re-examined her 10 minutes later. Once we inject the lidocaine, it should numb the pain fibers, and then she should have improvements in her range of motion and much less pain. And in fact, that was the case for this patient. Approximately 10 minutes following the ultrasound-guided lidocaine injection test, she noticed marked improvement in her pain. We felt very confident that the impingement process inside her hip joint was the main pathologic process driving all of her pain. We elected to move forward with surgery. Again, the plan will be to do an arthroscopic evaluation of the hip joint, essentially a couple poke hole incisions, stick the camera in the joint, take a look around. We'll get a chance to see her labrum and address the impingement process. We will come in here and elevate the labrum off and resect that bone and then repair the labrum down if possible. She may also have calcification of her labrum, which means it's not repairable, it's just too degenerative. And in that case, we would just do a simple labral resection for the time being, and most patients will respond very favorably to that. This should be about an hour-long procedure. The next step is we get her to the OR, get her to sleep, and start to evaluate her hip. So now what we want to do is we want to vent the hip capsule. We would just want to pierce the capsule so that we can distract her hip. Go ahead, Allie. That allows us to get a much easier distraction of the joint. Now that we've got appropriate distraction, we're going to inject the hip joint with lidocaine with epinephrine. This will anesthetize the hip joint and insufflate the joint. So that'll provide some anesthetic to the hip joint capsular tissue and synovium. And now we've distracted the joint. That allows us to get arthroscopic access so we can do the arthroscopic portion of the procedure of the case. Fluoroscopically get ourselves into the joint. You just have to make sure everybody has lead on so they don't get radiation exposure. And so our starting point is the tip of the greater trochanter. We just want to slide about a centimeter anterior to the tip of the greater trochanter. You actually want to come at a bit of a valgus angle. Go ahead. So you don't want to come straight horizontal or you end up piercing the labrum. Even there, I'm a bit too close. Go ahead, Allie. That's better. We're sneaking right above the tip of the greater trochanter. The gluteus medius actually has a very small tendon unit from the end of the muscle to the tendon. So I want to just try to get into the muscular portion of the medius. Go ahead. And sneak right over the femoral head like I'm doing there. Go ahead, Allie. Then we'll use a guide wire to get in here. Picture, Allie, so we can see we're at the base of the acetabulum. And we can actually see the soft tissue silhouette of the labrum. And I'm sneaking between the labrum and the femoral head there. Make a small incision. I actually use these soft cannulas that were originally designed by Pivot Medical, which they were bought out by somebody else, but I like the soft cannulas because they're less traumatic. Go ahead, Allie. Go ahead, Allie. Okay, back out, Allie. There we are, we're in the joint. We can see femoral head to our left, the acetabulum to the right, the labrum up above us. And so we don't have a lot of space to work right now, but what we're gonna do is make a second portal. And when we do that, we'll make a cut in the capsule, which will give us the opportunity to switch our view and give us some room to work. But we can see that we snuck right between the labrum and the femoral head. Now we make what's called a mid-anterior portal. We just come in and basic arthroscopic technique, just triangulate ourselves. And there we snuck right between the two. Once again, and that's under direct visualization. Same process, guide wire in, skin incision, and then one of these softer cannulas will come through. And now we'll turn our inflow on and get some water flowing through the joint. And we'll begin our evaluation of the hip here in a second. And we can see to the right already some fraying of the labrum. The first thing I'll do is switch views, actually. I like to look down from that top portal and look lateral between the two portals so that we have a good release and we can do what we need to do arthroscopically. You have that other gray canyon, please? The only portal we make blind, and we want to make sure we didn't pierce the labrum or cause any damage. All right, samurai. So we'll bring this knife in. It's called a samurai, which is basically just a knife, so we can cut the capsule and give ourselves some room to work and relax the tight capsular tissue. And we can see, look how degenerative her labrum is laterally here.